right, it is 8 a.m. Happy New Year's, everyone. We'll go ahead and get started. My name is Kelsey Brown. I'm one of the staff pathologists here at Coplow, and I have two cases I'm going to take you all through. So our first case is the globe from a 2.5-year-old female spayed mixed breed border collie. And let me bring up the history. I had to screenshot it here. So early in December, this dog sustained blunt trauma to the left eye. They had a bungee dog toy. They grabbed one end, ran with it, and then the stick end flew back and hit them in the face. They screamed, cried, dropped the toy, and ran into the house, and then were acutely painful. Kind of a very sad history. So I provided a picture of the potential bungee toy. I mostly picked this one just because of how not to scale it is. It's kind of funny to look at. And then we did not take a photo of the globe. Really, we just saw a bunch of hemorrhage in the globe, so I just chose a representative photo to depict that. All right, so we will go ahead and switch to the histology for this globe. Pick the right one. Cool. So starting at the anterior segment of the globe, our cornea will be on the left, and then our posterior segment is going to be on the right. We'll move back that direction. There is some pretty mild vascularization coming in at the periphery of the cornea. This is a fairly acute timeline. I guess I didn't mention that, between when the trauma was sustained to the eye and when the eye was enucleated, about 3 days. So that's pretty fitting that we don't have too much vascularization. Here's more of it on this side. And then in the kind of paraxial region of the cornea, we do have this little area where the epithelium is hyperplastic, and it's a little bit weird looking, for lack of a better word. So we'll go ahead and look at that a little more closely. Then there is our lens fibers are luxated into the anterior chamber. We'll go closer. There really is not much of a capsule around the fibers themselves. As we move back to look in the posterior chamber, there's a little curled fragment of lens capsule still here associated with the ciliary body. Then if we fan to the other side, there's a little bit more here as well. And from here, we can see that perhaps there is liquefaction of these lens fibers. We have more lens fiber kind of spreading out through the anterior chamber over here as well. And there is some sort of cellular exudate within the anterior chamber, and cells are infiltrating these liquefied lens fibers. In a low power, we can also start to make out this little fibrovascular membrane on the surface of the anterior iris. And then moving back, as we saw grossly, there is a good amount of hemorrhage within our posterior chamber and vitreous in particular. And then at low power, the posterior segment is relatively unremarkable. Our retina and optic nerve head look all right. We'll look at the optic nerve head a little more closely. There are these areas of pallor that are somewhat interesting. But we'll start at the front again. There's this little area of the cornea up where the epithelium is hyperplastic. I'll go even one closer. And there are some apoptotic epithelial cells. If we look at kind of the neighboring epithelium, there's a pretty crisp basement membrane. These cells have somewhat normal kind of polarity. They look a little bit more organized. Then we have this region here where they start to kind of extend into the stroma itself. So we kind of talked about this site. This almost looks like collagenolysis. And so we wondered, could this have been the point of contact with the bungee toy, which is kind of speculative, but kind of an interesting finding, especially given that the rest of the cornea is somewhat unremarkable. Looking at our lens here. So as I mentioned, our lens capsule is no longer associated with these lens fibers. These areas where we have these large pools of liquefied lens protein, and infiltrating that are scattered neutrophils. Inflammatory cells theoretically should not be able to extend through an intact lens capsule. So the fact that we do have a pretty substantial phakitis is supportive of a lens capsule rupture. And then just keep showing our little pre-iridal fibrovascular membrane here. As we move to look at the posterior aspect of the iris, there are areas of necrosis. So this pigmented iris epithelium is kind of lifted away from the stroma. There's a little bit of maybe artifactual lifting too here, but there are areas where that epithelium is instead replaced with necrotic debris and then just free melanin pigment, which uveal necrosis can be a feature of acute glaucoma, which in this case, they had said yes to glaucoma. So likely that's what's happening here. And then as we move to the back of the eye, it'll focus. There we go. Inner optic nerve head. There are these areas of increased pallor or rarefaction, and it's really pretty minimal in this case, but there are some neutrophils that are also infiltrating this rarefied optic nerve head, which similarly can also be a feature of acute glaucoma. We don't have the cupping or atrophy of the optic nerve head that we usually see with more chronic cases of glaucoma. And similarly, we don't see any retinal atrophy because this is relatively acute. With acute glaucoma, we can see necrosis of these individual ganglion cells, which was not a feature in this case. They look pretty unremarkable in this case, a pretty immaculate retina. So I think those are the main features here. So
Given the
yeah.
character of the trauma, can you see an intraocular coup contra coup with the vitreous mass? If it impacts and bounces around and traumatizes the retina, etc., will you see optic nerve head changes?
That's a good question.
See mostly retinal changes.
Retinal changes.
Yeah, I would call it retinal contusion. And that will look like outer retinal atrophy. The interesting thing is that those blunt traumatic lesions that cause retinal contusion usually causes a delayed degeneration of the photoreceptors. The classic example are ballistic or war-related like plastic lesions, where soldiers are shown to go blind 24 to 48 hours after they receive a blast.
Mm-hmm.
That's because there's that delayed diffuse or segmented to diffuse degeneration of photoreceptors. We could see that it could be that it's just too acute, or that the blunt trauma wasn't enough to cause severity of that.
It's just a weird pattern to see.
Right. With the optic nerve, I can't think about contusive optic nerve diseases. We get hemorrhage of the optic nerve, but if you have proptosis, then you will have a possible tearing of the optic nerve. Or if there's peri or orbital edema, you can have a compressive ischemia, like compartment syndrome type lesions. Yeah, good question.
All right, I will move to our diagnosis here. So pretty much everything we saw in this globe just corroborated the history of trauma to this eye, causing potentially this kind of weird focal collagenolisis, ultimately pre-iridal fibrovascular membrane formation, lens capsule rupture, and then the severe intraocular hemorrhage. We were able to see features of acute glaucoma, which was probably secondary to the fibrovascular membranes. And then also there was that luxated lens material, which also could have been causing pupillary block and acute glaucoma. So nothing too surprising that we saw given the history, but kind of, yeah, an interesting, very descriptive history for this case, which we always appreciate. All right, so if there are no other questions, I can move on to my second case. So this is the globe from a almost 13-year-old female spayed mixed breed pug. And she has a history of hyperproteinemia, as well as mild anemia and mild azotemia. So this eye developed hyphema and glaucoma. It was painful and non-visual and did not respond to any medication. So grossly, we described this globe as ophthalmic, and we described a solid cloudy gel in the vitreal space as well as the subretinal space. So here's that gel. We have our detached retina here.
Yeah, just for those watching at home, when we say gel, like this is semi-solid. Like it doesn't it's hard to convey that, but imagine if you're trying to bulk that, it will probably not pierce the surface almost sometimes.
Very weird jello.
Yeah, very dense jello.
They've changed directions in it.
Like right here.
Yeah, exactly. That's an excellent point.
Yeah. A helpful artifact.
Yeah.
Yeah. Mm. All right, so similar to the last case, our cornea is going to be on the left, and then the posterior segment is going to be right as we move this way. So in this case, pretty mild changes to our cornea, so some peripheral vascularization. The rest of the cornea is relatively unremarkable. Focus this better for you all. There we go. There is a pretty robust fibrobascular membrane on the anterior surface of the iris, and it's causing this very marked outward folding of the iris, or ectropion uvea. Move to the other side. I think this shows maybe that membrane a little better, and a slightly more mild ectropion uvea. There's a little bit of hemorrhage in the anterior chamber, potentially just associated with this fibrobascular membrane. They do like to bleed. Lenses within normal limits. And then as we move into our posterior segment, there is indeed retinal detachment. Here's a segment of our retina. There's a good amount of hemorrhage in the subretinal space, as well as the vitreous. And then a large amount of this eosinophilic or very proteinaceous material. Kind of fan over here. So here's more of our detached retina. And then in areas, we can start to make out kind of this brown pigment. So this is hemosiderin, indicating that this is a more chronic hemorrhagic process. And then they did say that this globe did have glaucoma, which is a little harder for us to diagnose when we have retinal detachment. Our optic nerve head is rather distorted by that detached retina. I don't have too much else to say about the iris here. I think I showed kind of the main features. There's a very mild lymphoplasmacytic anterior uveitis, so some scattered lymphocytes and plasma cells in our iris stroma. I'd say most of our important features are going to be in the posterior segment here. So this is our detached retina, and there's areas where there's just full thickness atrophy. We really can't make out any of the normal retinal layers. In some areas, maybe we regain some of those layers, so there's still some ganglion cells here. However, we have pretty profound atrophy of the outer to inner nuclear layers, which could just be a consequence of the retinal detachment, causing ischemic injury to the outer retina. And then just moving into our subretinal hemorrhage. Indeed, there's some hemosiderin within macrophages, indicating these macrophages have been in here to clean up this blood. Again, just supporting that this is a more chronic hemorrhagic process. And then just a sea of proteinaceous material in the subretinal space. And then just looking at our vessels. In the majority of our choroidal peripapillary vessels, most of them are just filled with this kind of proteinaceous, there we go, proteinaceous homogeneous material. In some areas, there are some settled erythrocytes as well. And then otherwise, as I mentioned, optic nerve head is rather distorted. The optic nerve is mildly gliotic, which we can see in case of glaucoma. It's by no means pathognomonic, though. Just a supportive feature in this case. So those are our major features of this globe. So I will go to our diagnoses. Talk about this. So major finding this globe is going to be the intraocular and the intravascular high protein serum with hemorrhage within the subretinal space and vitreous. Paired with the fact this dog has a documented hyperproteinemia, it's most suggestive of hyperviscosity syndrome. So this is a syndrome that we see in cases with increased red blood cell, white blood cell mass, or with increased total serum protein. And it causes high viscosity of the blood, and it causes issues with blood circulation. You can see thrombosis, excessive bleeding. And in the globe itself, some key features that we tend to see with that is going to be intraocular hemorrhage, the high protein exudate within the ocular chambers, as well as retinal detachment. And then another finding that we can see in these globes that was not present here is typically there is a uveal and or retinal necrosis, which just wasn't really a finding in the particular section that we had. But in this case, the fact that this dog had the hyperproteinemia indicates that maybe they should be searching for some sort of neoplasm that can manifest with hyperproteinemia, so like multiple myeloma, or depending on the region and kind of the clinical history, infectious etiology like Ehrlichia, something that can cause a monoclonal gammopathy. And as I mentioned, we weren't able to confirm the glaucoma, but we certainly had causes for it. So we had that very robust fibrovascular membrane that was causing peripheral anterior synechia, so likely a secondary glaucoma.
A question that sometimes is asked about those cases, especially when we suggest the possibility of neoplasia, it's about the presence of neoplastic cells in the eye itself, and that's not very common in those cases. So you know, as a diagnostician there, as a pathologist, I wouldn't be concerned of not finding neoplastic cells in the eye itself with hyperviscosity syndrome, if you're suspecting hyperviscosity syndrome, let's put it that way.
One other thing I wanted to bring up is that whenever you have any kind of intraocular inflammation, you can certainly get leaky blood vessels that then you can get a high protein fluid in the eye. So keep that in mind. So the key here is that we have a similar hue of serum in the choroidal and peripapillary blood vessels, or well, any blood vessels it should be, but definitely we see it back there. And that would indicate that the stuff that's leaking out of the blood vessels, well, the serum in the blood vessels is a similar protein content to the stuff that's in the eye, and obviously that's very subjective. So we look for these other features as far as like necrosis and things like that. And in this case, we didn't really necessarily have a good reason for a lot of intraocular inflammation. So we didn't have like a corneal perforation. We didn't have like a really severe lens-induced uveitis or something like that to suggest a different reason for having leaky blood vessels and serum leaking out of them. So just keep those things in mind as well. And obviously the history is very helpful here to suggest hyperviscosity syndrome. And that's definitely something that we hope to read when we want to suggest this diagnosis.
You pointed out the hemosiderin when you were first introducing the globe. Do we know what the time course is for the formation of hemosiderin following hemorrhage in the eye?
Good question.
It's a good fun path question, I feel.
Yeah, maybe like that, maybe a little bit extended, just because the red blood cells, since they're floating in the vitreous and aqueous, which is a little bit more of a nourishing environment, I think red blood cells can remain viable a little bit longer than just, outside of vessels in the solid tissue. But the other end of the spectrum is also interesting, right? Because differently than a hematoma, subcutaneous hematoma, or an organ hematoma, because of how the ocular tissue is protected from the, circulation and all, macrophages have a hard time to get in and to clear it out. So the consequences of intraocular hemorrhage are much more severe because it will just stay there. The amount of blood that comes out has a tendency to linger longer. So the accumulation of hemosiderin and hematoidin and hemoglobin tends to be, exponentially just continuous because it doesn't get cleared up as fast as you would expect in other areas.
This is like a systemic issue. How often is the opposite eye affected? Or is it usually like unilateral and, or if they don't get it under control, will the other eye end up having this?
Can you repeat the question, please?
Yeah. So the question was, given that this is a manifestation of a systemic condition, how often are the eyes bilaterally affected? In this case, it was unilateral. I'll yield to our more seasoned pathologists who have seen more of these cases.
I don't think we have a good answer to that. That's a really good question. We've never gotten tried to get the follow-up about the patients to find out how often they become bilaterally affected. I think we have very few where we've gotten a double scoop, like both eyes enucleated at the same time. But
It is interesting also because if you think about a similar situation like with systemic hypertension, it's usually unilateral, right? So there's for some reason one eye goes bad first. The impetus for enucleation is usually development of glaucoma, right? So I guess if I have to bet, I would say the other eye might have similar lesions, but not as extensive as this one, and not enough to have caused glaucoma yet. That's why this one was enucleated first. I guess by the time, if the other one develops something similar, they are aware of the situation. And let's just say this dog has a multiple myeloma, right? Going for enucleation of the other eye might be very low on the priority list of their clinical procedures. You know what I mean? So that might be one of the reasons why we don't receive that second eye in this case.
It may also have something to do with historical details. I would say that it's an even mix. We get cases of both hypertension and hyperviscosity where there's a known history of similar lesions, maybe milder in the other eye versus the other eye is described as normal or not described.
Right.
So it may just be a matter of what types of history we're receiving as well.
Good question.
All right. If there's no other questions, I will pass the scope to Dr. Shaw. Slide.
Alrighty. Next case is an eye from a 10-year-old Dalmatian, spayed female. The history we got was in September, presented with hyphema and secondary glaucoma of this eye. No menace or light reflexes. The dog's blood pressure was normal. Thank you for telling us that. That's very helpful.
Yeah.
In about 7 or 8 days later, recheck improved, but still hyphema, IOP still elevated, blood pressure still normal. CBC chemistry and UA all normal. Infectious uveitis panel all negative. And then about 20 days after that, recheck, comfortable, still no light reflexes, IOP still slightly elevated. And then the owner elected enucleation for long-term comfort and histopathology to find the cause of the hyphema. So we received the globe, and it's kind of a hot mess inside, but basically there's a lot of hemorrhage. So we have hemorrhage and some sort of tan material in the anterior chamber, kind of lining up along the iris surfaces. It's surrounding the lens. The retina is a little bit hard to identify. This is actually the second half of the eye because I looked at the slide and thought, wow, we really need a gross picture of this case. So I imagine the retina is up here somewhere because it is detached. And then there's material in the subretinal space, including probably some gelatinous stuff, kind of similar to what Dr. Brown just presented, some hemorrhage, et cetera. And then the lens itself is a little bit cloudy, so there's a cataract. So those were the main gross findings. All right. Subgross view. So there's the cornea. You can see that the iris leaflets are nicely adhered to the anterior lens capsule, so that is consistent with posterior synechia. And you can see that they're kind of bowed forward a little bit, so there's evidence of iris bombay as well. The lens is looking fairly normal from this magnification. Back here we have detached retina that's not completely sampled, but there's a bunch of hemorrhage and some high protein material there in the subretinal space. And then I'm going to draw your attention to this area here, which is a little bit busier than it should be. So, dive in. Moving from front to back, the front is not so exciting compared to what is happening in the back. So let's see here. There's a very mild peripheral corneal stromal vascularization, which happens whenever the eye is ticked off or when there's a corneal ulcer. So here we have the iris. As I said, it's sort of, there's this membrane that sort of also entraps some of the iridociliary epithelium, causing posterior synechia. There's some iris stromal hemorrhage as well. So we've got that. There's a little bit of lymphoplasmacytic uveal infiltrate. So we've got a mild to moderate lymphoplasmacytic uveitis. These are pretty typical inflammatory cells. So some plasma cells, etc. Nothing too concerning about those guys. The lens, as I said, looked a little bit cloudy, grossly. So let's see what we have here. From here, you can see that these are intact lens fibers. And then we have these like lakes of fluid, basically. So this is consistent with cataractous degeneration of the cortex. And when we look more closely, we have degenerate lens fibers. So what we're seeing here is a bunch of Morgagnian globules. If any of these blobs had nuclei with them, we would call them bladder cells, but that is just sort of semantics. But these are all indications of cataractous degeneration. And here's one little lens epithelial cell that's migrated posteriorly. So that's another hallmark feature of cataractous degeneration. As we move posteriorly, we have some eosinophilic material, and there's a bunch of this like sort of golden brown stuff around, which is probably hematoidin crystals. And as we, so that's a good indication that this has been a very chronic process. And from the history, we knew it was at least a month, possibly longer, for when this dog started bleeding into its eye. So we're just going to continue to move backwards posteriorly. The retina is diffusely detached. And where's our optic nerve head? There we go. Here's our optic nerve. So there's hemorrhage within the optic nerve head itself. And then there's a bunch of cells around in that subretinal space. There's also quite an epichoroidal collagenous membrane. But the more exciting part I'm going to show you is over here. So here we have quite a dense layer of cells up against the exposed choroid. They are round cells. And they have some concerning cellular features. We've got some big nuclei, fairly prominent nucleoli. And maybe as we scan around, maybe you can convince yourself there are some mitotic figures. This might be a mitotic figure or a pycnotic nucleus. So this is quite concerning for a neoplastic population of round cells. So when I first read this case out, I suggested that this was lymphoma. There is involvement here in the subretinal space. Oops. And then when we start to look at the retina a little bit more closely, wherever it went, where's the retina? Where's retina? And also the subretinal space, some of these cells out here, some of them have similar features to what we were just looking at up against the choroid. A lot of these are also probably macrophages, like this guy here is probably a macrophage, but some of these guys with the larger nucleus and less cytoplasm could be a similar population to what we're looking at. There's also some pycnosis occurring here as well, so some of these cells are degenerating. And there are significant areas of the retina that I thought were necrotic. And let's see here, like this area right here, here's retina that kind of becomes difficult to identify the retinal layers, and then we have a similar population of cells that's sort of in the retina. I diagnosed this as lymphoma. I suggested that this could be vitreoretinal lymphoma, which is a very rare form of lymphoma that we see in Coplow. I suggested IHC, which turned into quite the debacle because the first set of IHC stains, so I suggested a CD3 and a CD20. The first stains there was just a lot of background staining, and so it was really hard to decide whether what we were seeing was true immunolabeling or not. The histo lab did some finagling and tweaking of the protocol. And then they repeated the CD3 and CD20, and they also did a CD79A. I'm not going to take the time to show them to you. There were decent internal positive controls for all of those, but most of these cells did not label with either one convincingly. There were a few scattered cells, particularly up against the choroid, that had some nice, crisp, membranous immunolabeling for CD3. So we concluded that this was a CD3 lymphoma. The dog, they said CBC, Chem, UA, and infectious disease testing were all normal. So I asked them if they staged the patient, and I've never heard back. So I don't know if this is a primary intraocular lymphoma or primary solitary ocular lymphoma is what it's typically called, versus part of systemic disease. In humans, primary vitreal or retinal or vitreoretinal lymphoma is often associated with CNS lymphoma, not necessarily at the exact same time, but it's known that folks who are diagnosed with this type of lymphoma often develop CNS lymphoma. And as you can imagine, these are both sort of immunoprivileged sites, immunoprivileged sites because of the blood-retinal and blood-brain barrier. So treating these can be kind of difficult. You can treat, in human medicine, they can treat the intraocular lymphoma with intraocular chemotherapeutic agents, but that doesn't necessarily prevent the CNS lymphoma from developing. And I'm trying to remember what else. There is Dr. DeBilzig and Dr. Earhart published a paper about these a number of years ago. They only had 12 cases, and it was dogs and cats. There was a mix of T and B cell lymphoma. I think most of them were actually B cell. And most of them did not have known systemic involvement at the time of enucleation. So it's unclear whether these cases that we see, whether those patients go on to develop CNS lymphoma or whether this is part of systemic lymphoma. I think that's a project that's ripe for the taking, but it would require a lot of follow-up. Any questions about that? Let's see here.
Okay, so refine our immunomarkers.
Yeah, Dr. Gasper, who's here in the audience, definitely helped me look at the IHC. And it was difficult to make up our minds about that one. So there we go. There were a whole bunch of diagnoses in this case, but I decided to distill it down to these. So, yeah. So the next case is a globe from a 5-year-old boxer, neutered male. The history we received was history of, I'll just give it all away here, congenital cataract and fetal vasculature, / PHPV, which stands for persistent hyperplastic primary vitreous as a pup. So this dog has had this for its whole life, basically. It only recently developed glaucoma, which is the reason for enucleation. The globe is ophthalmic. There's chronic hyphema, corneal edema, and vascularization. The other eye is normal. So apparently this dog only has unilateral disease. So I'm sure that history prompted the person who grossed it to take the image. So here we have a ophthalmic eye. The cornea is pretty cloudy up at the top here, and there's peripheral pigmentation of the cornea. The anterior chamber is actually difficult to make out. There is this very dense sort of off-white tissue with a little bit of brownish discoloration in the anterior chamber. Here is the iris. Here is the lens, which is actually sort of difficult to recognize as lens, but there's lens capsule here. You can almost see that sort of translucent capsule around it. And then here we have what's left of the lens nucleus, lens material. The retina is diffusely detached, and you can see it as this stalk extending from the back of the globe anteriorly up against the back of the lens. And there is a substantial amount of subretinal hemorrhage. There's probably also vitreal hemorrhage and hemorrhage in what remains of the posterior chamber. Okay, the eye is pointing down here. It'll point up. Oh, I'll do this. It's an oddly shaped eye, so they embedded it differently, or they captured it differently on the slide. All right, so there is our cornea. Here's that off-white material I mentioned in the anterior chamber. Here's the iris. It's actually kind of thick and fairly heavily pigmented. This is a boxer, so we should always consider uveal pigmentation issues in boxers, mostly uveal melanosis versus just simply a heavily pigmented uvea. And you can see that the ciliary body is also fairly heavily pigmented there. There is hemorrhage in the posterior chamber. Here is what's left of lens. You can certainly identify the anterior lens capsule there. And then here's this collagenous plaque that's on the back, or well, kind of, it's hard to tell whether it's in the lens here on the back of the lens. And then the retina is diffusely detached and variably atrophied. And back here we have the optic nerve head, which is distorted by the detached retina. So this is a very nice case illustrating the sort of classic features of PHPV, persistent hyperplastic primary vitreous, and or persistent tunica lentis. Tunica vasculosa lentis. There we go. So this eye had fairly significant corneal disease, probably due to exposure and blindness. There is epithelial hyperplasia and keratinization. The stroma is a little bit disorganized and hypercellular, so that's corneal stromal fibrosis, and then it's vascularized as well. As we move around a little bit, you can see how wrinkled Descemet's membrane is, and it's actually focally discontinuous here. So that is probably Hobbs stria, or a stretch mark of the cornea. And then in the anterior chamber, you can see it is basically filled with and occluded by this collagenous material with blood vessels in it. And there's a few inflammatory cells around here and there, and probably some melanin-laden macrophages and or hemosiderin-laden macrophages. So here's a cell with some brown stuff in it. As we move back, here is iris tissue. It is more heavily pigmented than we would normally expect for a normal brown dog iris, and it is very mildly expanded. So I think I did suggest that this eye has uveal melanosis. There is a post-iridoral sort of collagenous and fibrovascular membrane that is causing broad posterior synechia to that lens capsule. The lens capsule is here. This is the anterior lens capsule because it's quite thick. And as we followed around, it is discontinuous right here. So we have lens capsule discontinuity / rupture. I think with these congenital abnormalities, you can actually have failure of closure of the lens, the posterior lens capsule. So it's hard. I wouldn't necessarily suggest that this was traumatic rupture of the lens. And as we follow it back here, there's our collagenous plaque that we were seeing. So this is really sort of on the outside of the lens as opposed to inside it. It is dense collagen, and there are quite a few blood vessels around. This could be part of some sort of persistent fetal vasculature. I might suggest this is more consistent with persistic tunica vasculosa lentis, but it could also be just simply PHPV. I'm going to stop saying all of those words. Anyway, so this collagenous plaque is like one of the nicest hallmark features of persistent fetal vasculature in the eye. And there's often a cataract that goes with it. We have very few lens fibers remaining in this eye. You can see there's more of that posterior lens capsule that's quite convoluted and wrinkled. And then the retina. The retina is frequently detached in these cases, as it is in this case. When I moved back here, I did not identify an actual single blood vessel that is what we think of as the histologic feature, or just feature, not to say histologic, but the feature of PHPV is at least a single blood vessel traversing the vitreous up to behind that retrolenticular area. So the retina is detached and variably atrophied, which is consistent with just straight up retinal detachment. And then when we look back here, this is a nice example of optic nerve head atrophy, that you might initially say, well, it's sort of hard to say what's going on with the optic nerve head because of the detached retina. But actually what we're looking at right back here, I'll go higher mag, is the lamina cribrosa, which is that meshwork of collagenous beams through which the axons of the retinal ganglion cells traverse, and then they become the optic nerve posterior to that. So the lamina cribrosa, I'll go back to lower mag, should be at the same level as the choroid. So the choroid is up here. So this lamina cribrosa here should be all the way up here. So this is quite an atrophied optic nerve. So those are the main features of this case. I thought it was just a very nice illustrative case of PHPV, or at least persistent fetal vasculature. So here's some of the diagnoses that I included here. So a retrolenticular vascularized collagenous plaque that really is consistent with persistent fetal vasculature. And then lens capsule, I did say rupture here, but it could just be discontinuity, as I said, with a hypermature resorbed cataract, heavily pigmented uvea. Okay, so I maybe didn't actually go for uveal melanosis. Diffuse retinal detachment and atrophy, and mild lymphoplasmacytic retinitis. So there were quite a few other diagnoses here, including glaucoma. Boxers are the sort of number two breed, excuse me, for uveal melanosis, which is a non-neoplastic proliferation of melanocytes in the uveal tract that leads to pigmentary issues in glaucoma frequently. So I'm not sure if this dog just has a heavily pigmented uvea or melanosis, because there were quite a few other reasons for glaucoma in this eye. And that's it. I'm going to pass it on to Dr. Jamie Miller. Any questions for that case?
All right. Lots of cool, large, bloody eyes. So we're going to pivot a little bit and look at some less bloody things. So my first case that I have today is from an 8-year-old male neutered Maine Coon cat. It comes with the history that this cat presented in February of 2024 with bilateral anterior uveitis. The left eye, which is what we received, was much worse than the right eye. They did uveitis workup, which included a CT scan, CBC chem, FIV, FELV, toxoplasma titer, cryptococcus, ME, urinalysis, and aqueous humor cytology, all of which were negative. It did respond to medical management at that time. The cat then represented in August, which is what we have a clinical picture here of how the eye looked. The left eye, which is what is pictured, had rubiosis iridis and ongoing progressive worsening iritis / infiltrative disease of the iris. So we can see some evidence of that here. We got some pretty large blood vessels coming in here as well. And then again, progressing and getting worse in, about a month later here. And it kept getting better, kept getting worse despite being on topical and oral treatment. What the treatment was, they did not specify. And then here's the cat, even a month further. So just kind of more of the uveitis changes clinically there. Let's see. The other eye, the right eye, that had previous uveitis, they said is now resolved. So it seems to be mostly this left eye that's still having some issues. So they anesthetized the cat and did an aqueous humor cytology, as well as an iris biopsy. So we got 2 tiny tissues submitted in a cassette. They were at least big enough for us to be able to tell that kind of part of it was brown and part of it was tan. So we submitted the tissues. Sorry, there's a lot of construction noise going on. We submitted the tissues in origami. So you take some like lens paper, square lens paper, and fold up the tissues. We draw a little circle on it first with pencil, put the tissues in the middle of the circle and fold it up nicely and put it in a cassette for our histology team. So it's a little bit harder for that, or easier for them to find the tissues when they're that small. And ask them very kindly to try to do their best to stand these very tiny, small things on edge so we could get a good look of what we could of the tissue. So let's take a look at what we have. Right. So they did a wonderful job of orienting our tissues here. So we can see iris stroma tissue here. We've got the posterior pigmented iris epithelium along the backside here. And then we have our anterior surface of our iris. And as we go in closer, we can see that there's too many cells along the surface of the iris and infiltrating into the iris stroma. So these cells are kind of round to polygonal with distinct cell borders. They have kind of small amounts of eosinophilic cytoplasm, round to oval nuclei. It's kind of densely to finely stippled chromatin and occasionally these prominent nuclei. There are mitotic figures readily identifiable throughout this population. Some of these cells in here do have like a faint stippling of pigment in them. Here. So we were definitely concerned for neoplastic population in cats, especially feline diffuse iris melanoma was on our list, but we also couldn't rule out that maybe this represents lymphoma. There are a few non-neoplastic like lymphocytes and plasma cells scattered around in the stroma as well. So there's a very mild anterior uveitis in the background as well. We did offer immunohistochemistry melon A to look for the melanocytes and a CD3 and CD20 to look for T and B lymphocytes respectively. And they chose to do all three stains. The melon A stain, just for completeness here, the melon A that was run was a red chromogen melon A stain. We will oftentimes pick that in cases where there is uveal involvement because of all of the pigment within the uvea from the epithelium and the melanocytes there. It's a little less of a problem with cats because they have kind of few melanocytes and it's a little bit lighter staining. So it's maybe not the best red chromogen representation, but we can still see some of the positive cells. The cells that probably had those faint blush of pigment in the cytoplasm are staining positive here, but a majority of our population here is negative staining. So heading down the lymphoma track. Our CD3 immunohistochemistry here. I can find the iris biopsies. This one was back to a brown chromogen stain. You can see how all the melanin pigment still picks up pretty well in here. Ooh, sorry, small tissues is harder to navigate. That was close as I could go. All right. Oh no, I can go one more. There we go. So there are a couple cells in here that are kind of smaller with smaller condensed nuclei that have positive staining here, most likely T lymphocytes that are just kind of either part of the inflammation or kind of a background population amongst these neoplastic cells. And then lovely our CD3 for our B lymphocytes. You can start to sort of see the brown hue to it as we get in closer. And we have a nice diffuse membranous staining of these neoplastic cells for CD20. Uveal lymphoma for this kitty cat. As was sort of mentioned earlier, these can potentially be part of systemic disease, or they could be just primary ocular lymphomas. Presumed solitary ocular lymphoma is potential. That needs to be kind of ruled out clinically with staging the patient and seeing if there's any other disease with the cat. The ones that do get diagnosed as the presumed solitary ocular lymphoma have a little bit longer median survival time than those cases where there is systemic involvement. So we recommended just to make sure that there isn't any other systemic involvement in this case. And I don't think that they have.
Are you familiar with CD20 positive melanomas?
Can you repeat that?
Are we familiar with CD20 positive melanomas? No.
Let's chat about that.
All other pathologists are in here are shaking their heads no. So Dr. Gasper might have some interesting comments.
No, it's
That would certainly make things difficult.
There's a question here from Elisa Salas here. How easy it is for ophthalmologists to ID metastasis to retrobulbar lymph nodes? Good question. I don't think that that's a thing that we see very often.
There aren't retrobulbar lymph nodes.
Yeah, retrobulbar lymph nodes
So, right. Oh, wait, hang on. I just to clarify, I don't think there are any lymph nodes in the orbit.
in the orbit. Yeah, probably not in the orbit.
Okay.
I would expect the submandibular retropharyngeal ones to be the closest draining ones.
Yeah, mandibular usually are
Yeah.
the ones that are affected with.
And Taylor, drain to mandibular and parotid lymph nodes is the most common ones. Okay, next one.
Cool. All right.
Oh, yeah.
Oh yeah.
This is
So what we're looking at here is the cornea from a 7-year-old female spayed Bichon Frise that comes with a history of being diagnosed with bilateral keratoconjunctivitis sicca and progressive retinal atrophy. But their main concern, or more pressing concern at the moment, was that the center of the cornea developed an unusually darkly pigmented bubble-like mass, which was not present 3 months ago, presumably when they saw the dog. And let's see, I think I blew it up a little bit. It's pretty cool. Under slit lamp biomicroscopy, the mass seemed to be inside the corneal epithelium / beneath it. They did not want to potentially rupture the mass, so they didn't do any debridement or scraping. And the stuff did not wash out using, I guess, a BSS solution. So what they did is they took a keratectomy sample of this pigmented stuff, and they sent it to us. Okay. All right, so here is a couple keratectomy specimens here. We have superficial cornea stroma, and we have kind of thickened corneal epithelium that is abruptly disrupted and replaced by a mat of fungal hyphae and probably some conidia here. They're partially pigmented. I think this is about,
there.
yeah. We can go a little bit closer. Yeah, so all that pigmented stuff is pigmented fungal hyphae, fungal conidia. We can see it starting to, I am focusing
Wow,
up
okay,
and
it's
down.
not-
It's just sort of,
focus well.
yeah, it's, yeah. So we can see they've got kind of, sometimes they're parallel, sometimes they have bulbous walls. There was various right angle and acute angle branching going on. Surprisingly, not a whole lot of inflammation associated with this fungal infiltrate. We did wonder if, since the dog was diagnosed with bilateral KCS, if the dog has been on immunomodulatory treatment, and so that could explain the lack of inflammation. So some nice conidia here, a little bit of branching, a little thinness, that stuff. And so, and then just to see things better and to give you some color in your life this morning, we did throw on some special stains. So here is a GMS stain. So we can see that it highlights the fungal hyphae organisms very well. We can see that it starts to sink or infiltrate into the corneal stroma. We can see where areas where the cornea epithelium is intact, that there are fungal hyphae also present here. Again, you can see the cute little bulbous stuff going on here.
That is the cutest thing,
It's
isn't it? Like,
it was just fun.
and the gross picture.
Yeah, it was great. It's always wonderful to receive our clinical pictures from our clients. And if black wasn't the color of choice that you were looking for this morning, here is a PAS for fungus,
It's just
which,
from therapy of the day.
yes,
Soaking that happiness,
soak it in.
yes.
Yeah. So cute, fun little fungus.
Yeah. It's fun that it has all these conidia forms in the end, and
Mhm.
you often see those when these fungi are exposed to air, which makes sense here on the very surface of the cornea, or when you have those big pulmonary cavitary lesions where there's access to oxygen. So we were joking that it probably, if you blew on this dog's cornea, that would be like a puff of like mycelial cloud, black mycelial cloud, I guess.
Yeah.
Actually, go to the right again.
Oh,
Up
yes.
under the epithelium. I don't care about the fungus. Go to the left now.
Ooh.
Well, actually, there.
Yeah.
That interesting PAS positive stuff is probably irregular basement membrane,
Okay.
which is probably, well, I think that this would be considered what Dr. D said is a hallmark feature of previous ulceration, but definitely sort of an abnormal basement membrane. You can see where it's separated from the basal layer there.
Yeah.
So kind of interesting.
Yeah.
Another interesting thing or debate that came after we saw this case was the fact that it was so localized and so like B, and when you see the histopath is even more impressive because you got these very localized regions. So we wonder about a potentially a traumatic inoculation of those fungi in there. But And it's interesting that you can see them away from those big
Mhm.
fungal plaques where smaller lesions where they're subepithelial. Very cool.
So histopathology is a terrible way to try to speciate fungal organisms. There is a fungal PCR available at Florida, University of Florida. It I think would probably only give the genus if possible. We haven't had super great success. We often get a lot of contamination results, but it also wouldn't give sensitivity. So definitely fungal culture and sensitivity would be the best way to try to identify these organisms. So
All right.
cool. Just give you the
Nice seeing everyone online.
Yep.
Yeah, multiple.
Yep.
Sorry about that.
Yeah, just to throw up the diagnosis there at the end. Enjoy your color therapy for the day, and we'll see you in 2 weeks.
See you guys in 2 weeks. Thank you. Start the recording.